I have already I had a recording for infertility and loss. I've posted that recording for you because Ms. McMillan is coming, and um, I want to have time to review with you all for the final. So I'm going to talk about reproductive issues, and you already have the recording for infertility and loss. The common disorders we'll talk about are amenorrhea, dysmenorrhea, PCOS, endometriosis, and vaginal infections. If you don't know what the abbreviation for PCOS is, I was just ask you to look it up because it's something that is we're diagnosing it more and more for women. It's causing a lot of women to have a lot of weight gain, a lot of problems getting pregnant. So um, look it up so that you won't remember, so that you won't forget it. Okay, let's get started. And menstrual disorder vocabulary. This is a little slide I always like to use. It helps you to have an idea. If you don't know what a certain term is, you can look at this little helpful tip and it'll help you know what the different terms mean. I'm going to give you a page number here with chapter 5 where everything is starting. We're going to start with chapter 5. It'll be on page 77 for you all. You know me, I like to use multiple resources to help you all get what you need. Okay. Minnow is menstrual. Metro is time. Oligo, you already know this from oligohydramniosis. Few. A is without or lack of. Ragia, excess or abnormal. Dis, it either isn't happening or it's painful. Rhea is a flow, is the flow. So common reproductive order disorders for women usually have to do with menstrual problems, or she's infertile. There are problems with contraception. She has problems having spontaneous abortions or menopause. That is what happens later whenever we get over 50. Amenorrhea, most of us women, most of you girls know what it is. It's absence of menses during our reproductive years. There's two types. One is that by the age of 14, she has had no menses at all and hasn't developed secondary sexual characteristics. Or the other is absence of menses by the age of 16 but has had normal development. Secondary amenorrhea is absence of menses in women who previously menstruated before, and it's related to, it could be some other disorder. So, what is primary amenorrhea? Going backwards, sorry. Okay, so how do we determine dysmenorrhea or nursing assessment? What is the past medical history? What is her sexual history? What is her menstruation history? It's very important for girls to understand about their monthly periods and understand to pay attention to what's happening because we are going to want to know what that history is because the physician or provider or nurse practitioner, they're going to need to perform a bimanual pelvic exam. They may have pain, nausea, vomiting, diarrhea, just generally fatigued. They could have fever, headache, dizziness, bloating, retention of water, weight gain, muscle aching, food cravings, and breast tenderness. And all these things happen around the time for menstruation. So we have to educate what are some comfort measures? Do heating pad work? some lifestyle changes, what makes it worse, what makes it better, and of course, helping them determine what they can do for pain relief, preferably non-pharmacologic if possible, because they have these symptoms every 28 days. So here's some teaching tips that I like to give. These are not in your book. These are from another source that I like to use. Exercise is good. Limit salty foods. Increase their water consumption because that is a natural diuretic. Increase fiber. Use heating pads or warm baths, warm showers, warm beverages, decaffeinated or best. Keep the legs elevated when they lay down, knees bent, stress management, relaxation techniques to help them cope with pain. Stop smoking and decrease alcohol. Those are some other tips. So, dysfunctional uterine bleeding. This is similar and may overlap with other uterine bleeding disorders. Most of the time, this happens at the beginning or the end of the menstrual cycle. You'll hear some women sometimes say they were flooding, or they'll start real heavy and then all of a sudden stop and then start again. That's dysfunctional. Usually, this is related to some type of hormone disturbance. So she needs to go to her healthcare provider and treat the underlying cause. Our management involves mostly client education as a nurse. And going to the physician, being placed on an oral contraceptive is not always the best answer because oral contraceptives are hormones. So that should not always be the first choice. So, ladies, if this is the first thing your physician always wants to do when you're having problems, talk to them about something else and see if there are other alternatives besides going straight to a birth control pill to take care of menstrual cycles. Polycystic ovarian syndrome. This is PCOS. It is an endocrine disorder and it causes menstrual dysfunction. Oftentimes, then they will have an androgen excess. Oftentimes, they may be obese because it does create an insulin resistance. They have trouble getting pregnant, and to treat it, the physician needs to find the cause. Why is this happening, and how are we going to take care of it so that everything else will be in balance? Here are some treatment options for women who suffer from PMS or dysfunctional uh, menstruation. Reducing stress, exercise, of course, balanced diet, decrease their caffeine. Um, if it's really bad, you can find a support group. Vitamin and mineral supplements. If they eat well, sometimes they can find relief by taking an NSAID. It is suggested if they are placed on oral contraceptives to do very low dose. Diuretics if necessary, or some other type of agonist to a gonadotropin agonist. We really want to try to stay away from giving too many hormones or giving them for long term because of their risk for causing cancer. That's one of the issues is we'll put someone on a hormone to help them balance or hormone replacement if they don't have enough, and then we tend to not ever give them a break, and we don't want that to happen. Endometriosis is abdominal tissue that grows outside of the uterine lining. The exact cause is not known. Many times, if it's really bad, women will need to have surgery or be placed on medication. What we assess is she's either unable to get pregnant or having excruciating pain. There's a nonspecific pelvic tenderness, tender nodular masses on the uterosacral ligaments. You can see that in the picture. Or on the posterior uterus, or in the posterior cul-de-sac. And the longer she waits to get pregnant, if she suffers from endometriosis, the harder it is for her to get pregnant. So our education to women who suffer from endometriosis is for them to attempt to get pregnant as soon as possible if they are going to want their own children. Education, education, healthy lifestyle habits, and there are support groups available as well. I believe you've seen there's many TV commercials out now that talk about endometriosis because it is a problem. It can be treated if caught early. If not, she many times ends up having to have a hysterectomy very early. Surgical abortion, we've that's if they choose, or a medical abortion. This is where we give medications if the mother chooses to have an abortion, and this is really about all I talk about it here because this is a very controversial issue. And we also have what we've talked about in the past, spontaneous abortion, which is where moms just cannot hold a pregnancy and they lose their babies. So, menopause, what does it do to women? Um, the impact on the brain, she experiences hot flashes, wants to sleep a lot, has mood swings, and starts finding herself begin to have memory problems. Not the memory problems that we see with dementia or Alzheimer's, just a little bit of trouble recalling things sometimes. With cardiovascular, she'll start having lower levels of HDL and it increases her risk for cardiovascular disease. So this is why we tell women who get into their 50s, it's good to start taking a low dose aspirin to prevent strokes. It's good to start making sure we're exercising and making sure we're eating right, getting on a good cardio diet. American Heart Association, in my opinion, has the best suggestions for appropriate diet to watch for cardiac disease because there are many diets out there that say they are heart healthy, but go and take a look at the amount of fat used to cook with. Coconut oil, some of the plant-based oils that are on paleo and some of the other popular diets are maybe healthy in one regard, but in another way, very, very high in saturated fat, which are not good for cardiovascular health. And heart disease is very prevalent in women, especially over the age of 50. Our bones, we start having bone density loss and increased risk of osteoporosis. That's why it's important that we begin having bone density tests done and getting treated for osteo if it's caught early, because what happens to us many times is a hip breaks and we fall, or our ankle breaks and we fall. We don't fall and cause a break. We break first and then fall. Our breast, the duct and gland tissue is often begins to be replaced by fat. Genitourinary start experiencing vaginal dryness, stress incontinence, and cystitis because our musculature starts getting weaker because we've had children and hormones start changing and we start experiencing some of these things. We have less calcium absorbed in our GI tract, and so we have increased chances of having fractures, which is compounded by the risk for osteoporosis. Our skin becomes getting dry, gets more thin, and our collagen decreases, so that's why we start seeing our face starts falling, chin starts falling, everything starts falling. So, but it's all part of life. So during the transition, we want to make sure our women are continuing to come to the doctor to get checked out and stay healthy. We want to do screenings for osteo, for cardiovascular disease, as well as cancer risk because it increases the older we get. We want to find out what is their lifestyle, what do they do during the day, where do they work, to help prevent chronic conditions. If she just sits around all day and watches TV, or maybe she's retired early, what is she doing to stay active? We want to give her health maintenance education, how to reduce the risks of some of these things that are common after 50. There may be some lifestyle modifications that need to be done, and help her with some stress management activities. Yoga class, water aerobics, things that get you out and about and staying active. So Joy is now 47. She's a G2 P2. She's experiencing hot flashes and flushes and having night sweats, and she can't sleep well. She's got mild hypertension, but she doesn't take any antihypertensives. And she started walking 6 months ago. She feels her symptoms are interfering with her quality of life, so she's going to see the nurse practitioner to discuss natural and alternative therapies to help relieve these symptoms. So, why do we have these hot flashes and flushes and night sweats? What's going on? We do this because of vasodilation and vasoconstriction. And so, whenever our vessels dilate, that's when we flush. And we see them oftentimes have flushing in their face, and they'll start perspiring, or like a flash that's just a sudden warmth sensation. And night sweats is whenever there's profuse perspiration and heat that just radiates from the body during the night. Because we have that instability, our estrogen is now fluctuating. Um, and if we're having a natural menopause, this is what happens. And this usually occurs in the first few years of menopause. And over time, it does get better. So, why do these symptoms interfere? Well, I like to take a shower and start sweating. They're unpleasant. Um, they're not infrequent, although that's what our case study says. Sometimes they can be unpleasant in heat and warm. Some women will have them 20 to 50 times a day. Night sweats make you wake up, sometimes to the point that you have to get up and change clothes because you're perspiring so much. Because these can create intense anxiety for some people. Some people it really bothers them, so it interferes with their quality of life. Um, you get up sweating, you have a hard time going back to sleep, so sometimes that can lead to sleep deprivation. Most of these women do report not being able to sleep, having fatigue, and sometimes they do get. So, what are some of these comfort measures that we can clients with? Dress in layers so that if you start getting hot, you can take some layers off, and avoid different triggers that might bring on a hot flash or a flush. Sometimes taking a hot shower and then getting out and you start getting dressed and then you're going to start flashing again. So splash face with cool water, ice packs, drink cool water, take a cool shower, slow deep breaths, yoga, guided imagery. But about the time you start getting frustrated with a hot flash, then it's going away. Um, have her to take a fan with her. It gets embarrassing because her face gets red or she'll start sweating, but it's just one of those things, and it does go away with time. If you eat spicy foods, you're going to have a flash, or if you drink hot coffee, have a lot of stress, have a flash. So now we're going to talk a little bit about those benign disorders that can happen in the female tract. I'm not going to talk a lot about cancer because you did all that in MedSurg, and you'll do it again in MedSurg too. So we're not going to go there this class. So benign neoplasms in the reproductive tract. These can be cervical, endocervical, or endometrial polyps, or fibroids. I think some of you saw some clients with fibroids this semester. ovarian cysts, genital fistulas, or Bartholin cysts. So, some pelvic support disorders you'll hear, or some of you may have heard women say they've had a bladder drop or a cystocele or a rectocele, a uterine prolapse. Some of this happens because as our hormones change and musculature starts relaxing, bladder will start dropping down, the uterus will start dropping down, and we have to do something to help support that so that women won't. It is painful for some, and it can cause urinary incontinence, and that's not very pleasant. And sometimes we will go and do a small surgery called a bladder suspension to fix all of that. Pelvic support disorders includes all the pelvic organs begin to prolapse, and it can cause urinary and fecal incontinence. And this can cause physical and psychological morbidity depending on how terrible it is. There is weakness of all the supporting structures in the pelvis, from vaginal childbirth, advancing age, us doing heavy lifting more than we should be, poor nutrition, and getting overweight. So these are the types again. Cystocele, that's around the urinary area. Rectocele, you know where that is. Intracele can happen in between the cystocele and the rectocele, or a total uterine prolapse. So Kegel exercises are helpful. Sometimes physicians will place her on a hormone replacement therapy, but as I said before, this isn't like a continuous, because these can lead to development of a breast cancer. Dietary lifestyle modifications, sometimes if they lose just a little bit of weight, they'll have some relief. Pessaries or Colpexin sphere, you can read about those, and sometimes it is necessary to do an anterior posterior colporrhea, which is or a vaginal hysterectomy. If they've got too much prolapse, they'll go ahead and do a hysterectomy. So we want a health history. We want to find out about her risk factors. What is her history? What's her birth history? What are some things that she does that has put her at risk? Sometimes they're asymptomatic, or sometimes they'll feel like something is dragging, or there's a lump, or there's something's falling out of their body. The provider will do a pelvic, and they will do some testing to see how the bladder function is. Um, if you've ever done a bladder scan, to see after she goes to the bathroom and do a bladder scan to see how much urine is actually being retained. Sometimes they can't empty all the way. So a urinalysis, a urine culture, and a post-void volume will be done. So nulliparous women are at high risk for uterine prolapse. Yes or no? No. Multiparous women are at very high risk. Most common types of urinary incontinence when we get older: urge, stress, or mixed. Sometimes this happens a lot with nurses. We've tried to work long shifts holding the bladder because we felt like we didn't have time to run to the bathroom. The pathophysiology interplays with the bladder function, the pelvic floor muscles, neural control, and integrity of the neural connections for voluntary control. All of those are contributing factors. And so finally, after we have held our bladder for so long and for so many years, and we have an urge to go, we have to be having a bathroom. So here's a good chart that I found that helps you distinguish between the difference between what is urge incontinence and what is stress incontinence. Urge is when you've got a loss of urine and is preceded by a strong urge to have to go. You have to go, you have to go, have to go, and you can't get to the bathroom in time. Stress incontinence is whenever you have accidental leakage of urine and it occurs with increased pressure on the bladder, like when we cough or sneeze or laugh. And that's usually one of the things that the provider will ask, are you losing urine when you cough or sneeze? Because that's one of the things, if it starts happening, then they're going to start evaluating if you're a good candidate for bladder surgery. Stress incontinence usually happens in women when we get over 40 or 50 from our weakened muscles. And it's whenever it just involuntarily happens. That's why we've got all these cool products we can buy now, because we have it happen to us throughout the day. So, urinary incontinence for urge urinary incontinence, it's we can train with bladder training or Kegel. There may be a pessary that she can use, or an anticholinergic, or surgery if all of these other methods fail. For stress, we are going to see if maybe she'll lose some weight, stop smoking, don't get constipated, do some Kegels. They may try pessaries first, or vaginal cone injections, or duloxetine is a medication often that can be used. It's also used for depression, to try it to see if it helps, or estrogen therapy, or surgery. So, history and physical, again, always important. We will do urinalysis and urine culture and urodynamic testing to see how much leakage she is having post void. It's very important that we talk with her about treatment options and those good bladder habits. When you first feel like you need to go to the bathroom, go ahead and go. You have time. How long does it take, right? Go ahead and go, and give them a lot of support and encouragement. That it's not pleasant, but it's one of those things that occurs. So, what type of drug would we expect for a woman to be given with urge incontinence? Which one? Anticholinergic, like oxybutynine or tolterodine. I always have trouble saying that. That's what's mostly prescribed for urge. Um, those side effects, because it is an anticholinergic, they'll have dry mouth, blurred vision, constipation, nausea, dizziness, headaches. The same types of side effects that you would have from any other anticholinergic that you using to dry somebody up, or one that you would dry up their sinuses, that have the same type of effect. So, why do we not talk about these things? Because urinary incontinence is inevitable and not treatable, so we think, why talk about it? We feel like that it's just a normal part of aging, or we feel like it's part of being a female, so we just have to accept it. Or we feel like it's a hygiene problem and not a medical condition, but there is treatment. There are medications that can help to take care of these issues. Polyps, most of the time they are benign, and I'm talking about in the reproductive tract now. They're frequently a result of infection. The most common are in the cervix or in the uterus. Cervical polyps often appear after menstruation. The endocervical polyps usually occur in women who are between the ages of 40 and 60. The endometrial polyps are rare in women who are less than 20, but they peak about at the age of 50, and they usually will go away after menopause. So if they are too large and painful, usually during a hysterectomy or a D&C, they'll either can remove them with forceps, or they can zap them with a laser to if they get in the way. Excuse me for a moment. Okay, sorry about that. I believe we got finished talking about how polyps would be removed, so we'll move on. Endocervical polyps, the color is usually a cherry red. Whenever they get into the cervical area, they turn more of a grayish white. And as I said, these are often asymptomatic, but if they get large enough, sometimes they'll cause abnormal vaginal bleeding or a vaginal discharge, or a metrorrhagia with endometrial polyps, where it, it bleeds. Sometimes it's painful. Endometrial polyps are often detected by ultrasound, or they will go in with a scope. So it's education, explanation, what's happening, reasons why we might need to remove them, and any type of follow-up care instructions. Or fibroids, these are sometimes called leomas or leiomyomas. They're usually benign, but sometimes it's hard to know. That's why they need to be checked out. These grow very rapidly during childbearing years because of our increased estrogen levels, and these fibroids depend on estrogen, and they usually shrink during menopause. This peak incidence is around age 45. And as I said, the etiology is usually these come up, and it's because of estrogen. So they may be given a gonadotropin agonist or a progestin antagonist, or the physician may need to go in and do a uterine artery embolization or a myomectomy, a laser surgery. Sometimes, if they're large enough, she may need a hysterectomy. So, her health history, she'll get a pelvic exam. Confirmation is done by ultrasound. She'll need the same thing as anyone having surgery, pre-op teaching, post-op teaching, and how to take care of herself afterwards, depending on what type of surgery is done. Uterine fibroids are most common in postmenopausal women. True or false? Uterine fibroids have peaked at around the age of 45. We haven't gone through menopause yet at 45. Some women may have some premenopausal symptoms, but menopause usually occurs after 50. So, treatment options, here's another really good side by side table that you can use to know what the different symptoms are, different treatment options. And here's just a graphic of where some of these fibroids may occur. Genital fistulas, the common types can be a vesicovaginal, a urethrovaginal, or a rectovaginal. All depending on where it's located is why it's named a certain way. The therapeutic management for the very small ones, they will usually heal without treatment. Larger ones will have to require surgical repair, because you can see it's a fistula, it's an open area, it's a place where it can collect and cause all sorts of infections that we don't need. History. What are some of the common signs and symptoms that are related to the type of fistula? Um, a physical exam will be done for inspection and palpation, how large it is, how far it goes, if it's connected to anything else. She'll need guidance and support, and what the different treatment options are and what they will be. Like we said, if it's not very large, it'll oftentimes go away on its own. What we see a lot of times, if it's close to the urethra, she will run the risk of having infections. If it's towards the rectal area, there again, uh, infections. Um, that's a common symptom, but oftentimes a discharge. Um, Sometimes, if they do get infected, it will be malodorous. Bartholin's cysts. It's a blockage of one of the Bartholin gland ducts, and an infection can occur, and sometimes an abscess can form. oftentimes these do not, they get inflamed, they get better, get inflamed, get better. Oftentimes they're asymptomatic. But if the cyst gets larger, sometimes there is a protrusion into the labial mass, and sometimes if an abscess does occur, then she will have to have it surgically drained and taken care of. Most of the time, it's very conservative. Hot packs to try to help it go away. We all have Bartholin cysts. Females get them from time to time, and they usually will go away. But if they do start enlarging or are painful, we definitely need to. We hate to go to the doctor for these kinds of things, but we really need to keep from having a bad infection. Ovarian cysts can be follicular or in the corpus luteum, decolleteine, or from polycystic ovarian syndrome. Um, these we have to determine if they are benign or if they are an ovarian malignancy. Usually we'll look at them with a transvaginal ultrasound or a laparoscope, um, and they'll be removed that way so that they can be tested. Or we will try oral contraceptives to see if they will go away, because sometimes women do just have cystic ovaries, and they occur more during ovulation. And we'll give them analgesics. If she has PCOS, she'll be given medications as well as non-drug therapy and possibly some lifestyle changes. What are the signs and symptoms? PCOS, hirsutism, alopecia, virilization, menstrual irregularity, oftentimes infertile. Her ovaries will have cysts all over them. Sometimes she will be obese because of insulin resistance, a metabolic syndrome, which all of these things increase her risk for cancer. And you can understand why there is a psychological impact, because sometimes she even has acne. So, pelvic exam, pregnancy test to rule out ectopic. We'll do ultrasounds. We've got to determine the cause. Most follicular cysts regress and require no treatment. True or false? True. They seldom grow larger than 5 centimeters, and they will usually regress. We have these oftentimes around menstruation time or ovulation. So we want to give her education. She may need a referral for surgery. We want to give her support and reassurance, and definitely we have to counsel and educate if she is determined to be diagnosed with PCOS. Vaginal infections, read over those in your book. There are multiple. The most common is candidus, yeast infection. PID is a prominent one. PID is sometimes a precursor to endometriosis. So just read about the most popular ones. Like I said in your book, there are tons and tons of reproductive and women's health issues that time does not allow for us to go over each and every one of them. I'm not going over STIs this semester. You learned about those in fundamentals, and so there's no need to repeat those again. If you happen to see something about an STI on an exam or on your standardized, the information should be essentially the same that you've learned previously. So if I were you, just read over them in your textbook. I plan to have a review ready for you um, on the 23rd before Ms. McMillan comes to talk with you. So, any questions, please let me know.